really, God bless, in Pakistan, northern areas under flood, severe flood.
Yeah, it was so much that the whole of our hostel, that was first floor, up to the first floor, it was full of water.
Okay. I think this is first time after a very long time in the history of the Aptabad or KPK.
Yeah, in the history of KPK. In Aptabad, usually when there is a heavy rainfall, then we face these issues. But at this moment in KPK, this was the first time that there was such a big...
Like Swat, very...
yeah, Swat, Buner, even Sawabi. Two
very
villages.
sad incidents.
Yeah, in Sawabi, 1,000 people have died.
Yes, 1,000 died. That's the 1,000 died. Okay. Dr. Gupta, you are telling something.
Yeah, I just want to know that we actually feel difficulties in diagnosing the skin inflammatory diseases because they are partially treated. So
that is always a problem.
That's a big issue then. That
Dr. Stephen, yes, this is a very good question.
Yeah, I mean, I know I talked about that a little bit with psoriasis yesterday, that's really a common problem and that you don't always see all the classic features. And that's, again, a time where talking to your clinicians can be helpful because you often don't see everything. And certainly if they've been partially treated, but they're not responding well, that's another example when I will always try to rule out a fungal infection and do a PAS or GMS stain, because that can be the fact that it's partially treated but still not responding well or has not completely resolved. That's another indication for doing a fungal stain, even if it doesn't look like a fungal infection. But you're right, that is something that we struggle with as well, because it's frequent that the patients will buy something at the pharmacy to treat themselves, or they will go to a primary care physician before they will see a dermatologist and they'll get partially treated. That's a real problem for us as well. And sometimes it's a very difficult problem and you can't always sort it out, unfortunately. But you look for if there's still remnants of features that you could apply towards one of your classic dermatoses.
Thank you so much, sir. We actually always try to call our dermatologists and ask them to see the slide, and we provide our input, and then they give us the input, and in this way we resolve difficult cases.
Yes, communication with the dermatologist is very important. Absolutely. It's 9:30. Should I go ahead and get started on the next part?
Dr.
Or would you like to wait
Gupta,
for a little longer?
Dr. Gupta, that is why this forum we has created. These are not only the histopathologists and very stalwarts of the very professors and experts and other people from the dermatology are here. Not only you people feel problem in the diagnosis, but they also, dermatologists, feel issues in the differential diagnosis. That is why we are trying to, and that is why Dr. Stephen, thank you very much, because we have created this forum to discuss these all issues, so that in the future for our training, what can we do? In this forum, I have joined nationally and internationally people from the histopathologists and dermatologists. And I hope at the end of these our lectures and this workshop, then Dr. Stephen is coming here in Pakistan. Hopefully these all issues, Dr. Shagufta, I will welcome you and you come in Lahore, but we do not have time to even with Stephen to come and stay in Ahmedabad to discuss all these issues. But if you bring your students and if you bring your dermatologist, we will welcome. We will inshallah. Zunaira, are you there?
Yes, sir, I'm here.
Okay. Dr. Zaida Rani is there. Dr. Zunera, you are also from very important dermatologist, and because you have started this program with the communication at this one, can you let us know your issues at the end of the dermatologist?
Yes, sir, sure. The major problem we as dermatologists face is that we have difficulty in diagnosing certain cases which are clinically, of course, indistinguishable, and we need help from histopathology. But from my experience, I have faced many difficulties because probably dermatopathology is not a part that pathologists are most interested in, maybe, and we face quite a lot of difficulties because sometimes we receive reports of biopsies just stating that there is chronic inflammation or acute on chronic inflammation with no definite hint towards any diagnosis, whereas while taking the biopsy we are quite specific that we try to take the biopsy from a lesion to have a good yield.
Dr. Stephen, what is your
Absolutely.
advice for this?
Well, I think the critical advice is to make sure that your histopathologists have familiarity with the common reaction patterns, like I'm, lecturing on in this series. And because I think if you can put it into a reaction pattern, that helps your clinician and your dermatologist very much. That's the main thing, is you don't sign out something as chronic nonspecific dermatitis, because it's always something more than that. And if you can put it into one of the reaction patterns, and then, once you understand the reaction patterns, then you can be more refined in your differential diagnosis. So if you can put it in a reaction pattern and give a reasonable differential diagnosis, that will help your dermatologists the most.
But
Thank you
Dr.
so much.
Anita has asked the question, granulomatous lesion, fungal and bacterial granulomas without special stain. Please share your experience. Thank you in your advance. Dr. Anita has
Well,
asked
we
the
are
question.
going to talk about some granulomatous things, at least the palisading granulomatous diseases. I don't remember if it's the end of this lecture or the beginning of the next lecture, but we will be talking about that during this lecture series.
Dr. Stephen, in my practice, when I was in KE, we started a dermatopathology section. Most of our histopathologists do not take the interest. That is why in Pakistan, if you see, hardly there are few centers which are performing the dermatopathology. This is the big issues. The interest of the histopathologist is in the dermatology is not as compared to other like breast or lymph node and other issues.
Sure.
And
Although, I mean, in the United States, at least, dermatopathology is part of the required curriculum for pathology training. Now, not every
yes,
pathologist likes it and focuses on it, but it is a required component of the training.
yes, yes, I know there is a special fellowship in dermatopathology in
Yes,
USA.
where we
Yeah.
have that, but
Yes,
even the general pathologists have to have some training in dermatopathology before they can take their boards.
And that is why, Dr. Stephen, we have prepared this forum to send one or two dermatopathologists, histopathologists who are interested for the training to USA under your supervision on our own expenses, inshallah. In this way, we can build not only this teaching system, but also we can get so many benefits of the training. Okay, let's start. The time is there. أعوذ بالله من
Okay.
الشيطان الرجيم. بسم الله الرحمن الرحيم. قل هو الله أحد الله الصمد لم يلد ولم يولد لم يكن له كفوا أحد. With the name of Allah Almighty, who is the beneficent. And over to you, Dr. Stephen, Professor Stephen. We have already given your introduction, and no need to waste more time. We just go on starting the lecture, second lecture of Dr. Stephen.
Okay, so now I'm going to talk about where we're leaving the arena of inflammatory dermatoses with a predominant epidermal change, and we're going to talk about different patterns that are predominantly based in the dermis. So I'm going to start with the superficial perivascular pattern, And in this, just in cartoon form, you can see that the inflammatory infiltrate is concentrated around the superficial vascular plexus and that the epidermis doesn't show much epidermal change. And then after you decide that this is the pattern, then you want to look at what is the nature of the inflammatory infiltrate. Is it mostly mononuclear cells like lymphocytes and histiocytes? Is it mixed? Is it predominantly granulocytic like neutrophils and eosinophils, etc.? We're going to start with morbilliform drug eruption. This is one of the most common things that we actually see biopsied. And morbilliform drug eruptions are often very impressive clinically. You can see this widespread, macular or papular eruption, throughout the body. But microscopically, it's kind of boring, to be quite honest. I mean, it's not very exciting under the microscope. You tend to see a very mild superficial perivascular infiltrate that's usually predominantly composed of lymphocytes, although there's usually, though not always, a few eosinophils too. Occasionally, you will see some focal interface change when morbilliform drug eruptions, but in my experience, that's less common. You might see some blood vessel ectasia or dilatation of the blood vessels. Histologically, it is often indistinguishable from urticaria or viral exanthems, so you really need to coordinate that with clinical history. Here's an example of higher power picture of a morbilliform drug eruption. Again, the infiltrate is in the upper dermis. It's mostly lymphocytes, but you usually, again, though not always, see a few scattered eosinophils as well. Another thing in the differential diagnosis would be urticaria. Now, clinically, urticaria is characterized by transient pruritic plaques or hives that usually resolve in 24 hours. So they look different from your classic morbilliform drug eruption. Here you can see the hives. Microscopically, again, you see a normal epidermis. You'll often see some dermal edema. And then, again, usually a superficial perivascular infiltrate of lymphocytes. You'll usually see a few eosinophils, and sometimes you'll see a few neutrophils. A clue to the diagnosis of urticaria, it's not always present, but a clue to the diagnosis of urticaria is if you see significant intravascular neutrophils. And then sometimes there's also a deeper component, although most cases of urticaria are superficial perivascular pattern. Here's an example of urticaria. Again, histologically, this is indistinguishable from a morbilliform drug eruption, so you really need to know clinical history. Now, if you're lucky and if you see lots of neutrophils within the vascular lumen, that is a clue to the diagnosis of urticaria. It's not 100% specific, but it is a clue to the diagnosis of urticaria. So if I see this feature, I will suggest the possibility of urticaria in my comment.
Dr. Steven, can I ask here a question?
Yes.
Along with this presence of neutrophil in the vessels, the eosinophils are important or not important? Thank you.
Well, they're important, but they're not consistently present. I mean, we can see eosinophils here, because usually you will see some eosinophils around the vessels. So, but if you see, this combination with neutrophils like this in the vascular lumen, it is a good clue to the diagnosis of urticaria. So eosinophils are also important, but they're not always present. Urticaria, the differential diagnosis can include the urticarial phase of bullous pemphigoid. A clue to the urticarial phase of bullous pemphigoid is the eosinophils are lining up along the basement membrane. Differential diagnosis can also include an arthropod bite reaction. We'll talk about that in a little more detail. Arthropod bite reactions usually have a denser and deeper inflammatory infiltrate. And drug eruptions can be indistinguishable from urticaria, so you really need to know the clinical history. Practical tips or clues, remember urticaria is transient. If the eruption tends to last more than 24 hours, think about the possibility of urticarial bullous pemphigoid. Think about drug reactions. Also think about urticarial vasculitis and look for subtle evidence of vascular damage. I will talk about urticarial vasculitis in more detail. If you see neutrophils in the vascular lumens, suggest the possibility of urticaria when you have a superficial perivascular pattern. Here's a case of urticarial vasculitis, and I'm not going to talk about that in too much detail here because I'm actually going to talk about it in more detail later. All right, so again, urticaria, microscopically, you have a normal epidermis, you have dermal edema, and usually a perivascular infiltrate of lymphocytes, eosinophils, a few neutrophils. And again, remember, if you see intravascular neutrophils, that's a clue. Another entity with a superficial perivascular pattern is mastocytosis. Mastocytosis comes in 4 different clinical forms. The most common is urticaria pigmentosa. And there's also telangiectasia macularis eruptiva perstans, or TMAP. Sometimes you get a solitary lesion mastocytoma, and I guess really there's 5 forms. Sometimes you can get systemic mast cell disease, which we're not going to really talk about today. We're mostly going to talk about urticaria pigmentosa. Urticaria pigmentosa presents as erythematous to tan macules and papules. Mastocytomas usually occur in children as a solitary lesion. TMAP, or telangiectasia macularis eruptiva perstans, consists of pigmented macules with telangiectasias. These often present in childhood, but some cases will present in adulthood. The lesions will urticate or form a wheal if they're stroked. That's called Derrier's sign. Here's an example of urticaria pigmentosa. You can see these tan macules on the skin. Microscopically, you will see a superficial perivascular infiltrate predominantly composed of mast cells. Mast cells, if you see a superficial and deep mast cell infiltrate, wonder about mastocytoma. It's often necessary to do special stains to prove that they are mast cells. You can do stains like Giemsa, a leader stain. You can do immunohistochemical stains, and I like the stain tryptase. You can also do CD117. Here's an example of urticaria pigmentosa. You can again see this superficial perivascular infiltrate, and notice this, the tumor cells have this sort of bluish gray cytoplasm, or the lesional cells, not tumor cells, have this bluish gray cytoplasm. You may see a few eosinophils. There's an eosinophil here, here, and here, but mostly it's composed of mast cells. And that you can highlight here with a Giemsa stain. You can see the metachromatic granules here in the mast cells, and sometimes they become more spindled. Differential diagnosis can again include like a drug eruption, a viral exanthem, even normal skin, especially telangiectasia macularis eruptiva perstans is very subtle. You have to have a high index of suspicion. If you see cells with sort of bluish gray cytoplasm, think about mastocytosis. You'll often need to do special stains to prove that they're mast cells, like a Giemsa or leader stain. If you have access to good immunohistochemical lab, then I like the stain tryptase. The rule, my general rule of thumb, I don't worry about mastocytosis unless I see more than 20 mast cells per high power field. If the mast cells co-express CD25, that is associated with systemic disease. Just remember, though, that T cells also express CD25. Another common entity that we see with a superficial perivascular pattern is pigmented purpuric dermatosis, which also goes by the name of Schomburg's disease. Clinically, this presents as reddish-brown macules, usually on the lower legs. Again, microscopically, you get little epidermal change, although occasional cases will show some spongiosis. Microscopically, you see a superficial perivascular lymphocytic infiltrate with extravasated erythrocytes. And sometimes, if the lesion is a little bit older, you might see hemosiderin-laden macrophages. Occasional cases will have a lichenoid infiltrate, and those can go by the name of lichen aureus. The big differential diagnosis is like late-stage leukocytoclastic vasculitis, but there's no damage to no fibrinoid necrosis of the blood vessel walls. Here's a clinical case of pigmented purpuric dermatosis. You can see these erythematous macules on the extremity. And microscopically, again, you see a superficial perivascular lymphocytic infiltrate with hemorrhage, but there's no overt damage to the vascular walls. The differential diagnosis can include stasis dermatitis, which we talked about in the last lecture. Stasis dermatitis can also have some extravasation of erythrocytes, but the vessels have thicker walls, that lobular proliferation of thick-walled blood vessels. Post-inflammatory pigment alteration. In this, you have a mild perivascular lymphocytic infiltrate, but you have melanophages, not siderophages, and there's really usually no hemorrhage. The major differential diagnosis is leukocytoclastic vasculitis. Occasionally, pigmented purpuric dermatosis will have a lichenoid infiltrate, and you might get it confused with mycosis fungoides. In terms of practical tips, remember there's really no overt damage to the blood vessel walls. You don't see fibrin deposition. If you see pigmented cells in the dermis, they're siderophages, not melanophages. And just remember there is a lichenoid variant. This is an example of a lichenoid variant of pigmented purpuric dermatosis called lichen aureus. You see a dense lymphocytic infiltrate, but you still see some extravasation of erythrocytes. The differential diagnosis is leukocytoclastic vasculitis. In leukocytoclastic vasculitis, instead of being macular lesions, they're palpable, so they're papular, so they have palpable purpura. There's lots of different causes of leukocytoclastic vasculitis. We'll talk about a few of those in more detail. About 30% of all cases of leukocytoclastic vasculitis are related to medication reactions, so they're essentially a form of a drug eruption. And at least in the United States, about 3% of hospitalized patients with adverse medication reactions will have a leukocytoclastic vasculitis. So patients present with palpable purpura, again, especially on the extremities. The most common drugs include antibiotics, chemotherapeutic agents, etc. But any type of drug can cause leukocytoclastic vasculitis. Microscopically, you most commonly see a superficial perivascular infiltrate, but you can also see different types of leukocytoclastic with superficial and deep perivascular infiltrates, and I'll talk about those as well. You will see a perivascular infiltrate of neutrophils with leukocytoclasis or fragmentation of the neutrophils. You will see hemorrhage. You'll see fibrin deposition in and around the blood vessels. In drug-related cases, you'll often see a few eosinophils around the blood vessels as well. It is important to remember that you don't always see every single feature of leukocytoclastic vasculitis in a given biopsy, and it really depends on when the lesion was biopsied. Because in older lesions, the infiltrate may become mostly lymphocytic, and I will show you an example. So as a general consideration, you want to do a punch biopsy, not a shave biopsy, because the depth of the vessel involvement can alter the interpretation. It is best to get a lesion that is between 24 to 48 hours old. Before 24 hours, the findings can be very subtle. Around 24 hours is when you start to see fibrin deposition around the blood vessels. You'll see more prominent hemorrhage, and you'll see more prominent leukocytoclasis. After 48 hours, if the lesion is more than 48 hours old, you might see predominantly lymphocytes and histiocytes around the blood vessels instead of neutrophils. Rule out systemic disease. If you see a superficial and deep pattern of vasculitis, think about more serious systemic vasculitides. And remember, don't call something vasculitis in an ulcer bed unless you can see vasculitis well away from the ulcer, because you can get reactive leukocytoclastic vasculitis in the superficial aspect of the dermis beneath an ulcer. So be careful with that situation. So here's a fairly classic case of leukocytoclastic vasculitis. The infiltrate is around the superficial vessels. Notice that we have fibrin deposition in around this vessel. Notice all the dermal hemorrhage. Higher power picture, you can see the neutrophils around the vessels, and notice all these small little nuclear fragments. This is the leukocytoclasis or fragmentation of the neutrophils around the vessels. Here's fibrin deposition around this vessel and hemorrhage. Just a higher power picture demonstrating this pink amorphous fibrin around the blood vessel wall. These are neutrophils, and these small nuclear fragments is the leukocytoclasis. Now, this is an example of a late-stage leukocytoclastic vasculitis. You can see the hemorrhage. You can see some fibrin in around these vessel walls. But notice here's a damaged vessel, but it's mostly surrounded by lymphocytes, because in later stages, the lymphocytes will come in around the vessels. It's a higher power picture. Again, note here's the damaged vessel, and most of these cells are lymphocytes, although there may be a little bit of nuclear fragmentation of remnants of leukocytoclasis. Most of these cells are lymphocytes and histiocytes. So again, microscopically, you have a superficial perivascular infiltrate, predominantly neutrophils. You have leukocytoclasis, extravasated erythrocytes, fibrinoid necrosis of blood vessels, but you don't always see everything. In fact, if I just see neutrophils with leukocytoclasis and hemorrhage, I'm willing to call something leukocytoclastic vasculitis, even if I don't see fibrinoid necrosis of blood vessels. Again, another picture, leukocytoclastic vasculitis, neutrophils here, hemorrhage around the vessel, but I don't see fibrin deposition in this vessel. I would still call this leukocytoclastic vasculitis. Here's again that image I showed you with fibrin around the vessel. A type of leukocytoclastic vasculitis you should be aware of is IgA vasculitis, or also known as Henoch-Schönlein purpura. Primarily, this affects children. You get these purpuric skin lesions. They also frequently have abdominal pain or gastrointestinal bleeding and renal abnormalities. And this is associated with IgA immune complexes around the blood vessels, which you can do direct immunofluorescence for. Microscopically, it looks like a typical leukocytoclastic vasculitis. It looks like any other type of leukocytoclastic vasculitis. Histologically, you cannot tell IgA vasculitis apart from other forms of leukocytoclastic vasculitis. But if you do direct immunofluorescence, you can see IgA deposits around the superficial vascular plexus. And that finding in combination with the clinical history can help you make a diagnosis of IgA vasculitis. So the differential diagnosis for leukocytoclastic vasculitis can include things like Sweet syndrome, but in Sweet syndrome, you don't have vasculitis. Remember, you can get secondary vasculitic changes in ulcers, pigmented purpuric dermatosis in the differential diagnosis. I'm not going to talk about erythema elevatum diutinum today, but I will talk about granuloma faciale, which are both of these are types of chronic vasculitis. If you have a deep component to the vasculitis, think about an ANCA-related vasculitis, and we will talk about those later. Remember, you don't see every single feature of leukocytoclastic vasculitis in a given biopsy. If you see hemorrhage, a perivascular neutrophilic infiltrate, and leukocytoclasis, I think that is enough to make a diagnosis. You don't always see fibrinoid necrosis of blood vessels. If you're worried about IgA vasculitis, do direct immunofluorescence. And again, remember, you can see secondary vasculitic changes beneath ulcers. But the vasculitic changes are always going to be superficial and close to the ulcer bed. Urticarial vasculitis. This is a very subtle form of vasculitis. Up to 20% of patients with chronic urticaria can develop urticarial vasculitis. It's much more common in women than men. And the clinical history can be helpful. Patients describe painful, burning pruritic plaques that last more than 24 hours, but usually go away after about 3 days. They can sometimes relieve, when the lesions resolve, they can have residual purpura or hyperpigmentation. So this is a patient that had urticarial vasculitis. These look like hives, these painful pruritic burning plaques. And systemic symptoms are common. Patients will often have fever, arthralgia, angioedema, abdominal pain. You can see hypocomplementemia in up to 30% of patients. And when you do see this, it can be associated with other diseases like lupus erythematosus or Sjogren's syndrome. Microscopically, urticarial vasculitis is a very frustrating diagnosis because it's much more subtle than conventional vasculitis. You tend to see a sparse infiltrate with neutrophils, with or without eosinophils. You don't always see eosinophils. And you'll see a few extravasated erythrocytes, and you often don't see any fibrin deposition around the blood vessels. So do not wait to make a diagnosis of urticarial vasculitis to see fibrin, don't hold out for fibrin deposition. You almost never see it. If you see significant tissue neutrophilia, it's more common associated with hypocomplementemic urticarial vasculitis. So this is a case of urticarial vasculitis. It's pretty, you see this perivascular neutrophilic infiltrate. I don't really see any overt damage to the blood vessel walls, and you see a little bit of hemorrhage and maybe an eosinophil or two. This is enough for me to make a diagnosis of urticarial vasculitis. Okay, now we're going to switch to the superficial and deep perivascular infiltrate pattern. So Usually there's little epidermal change, but there are always exceptions. You have a predominantly perivascular infiltrate, and again, with a superficial and deep distribution. And this is just a cartoon form. You see, again, superficial and deep, predominantly perivascular inflammation. And we're actually going to stick with vasculitis for now. We're going to talk about granulomatosis with polyangiitis, also goes by the name of Wegener's granulomatosis. Clinically, you see this in middle-aged patients with a slight male predominance, more common in Caucasians. It's a multi-system disease. Triad, the classic clinical triad is necrotizing granulomas involving the upper respiratory tract. And you get generalized vasculitis, often involving the lungs, but frequently involving the skin as well. And you may get renal disease with glomerulonephritis. Up to 1/3 of patients have neurologic involvement with neuropathy and cerebral lesions. You can get ocular involvement, and cutaneous involvement is anywhere from 15 to 50% of patients. And you get a vasculitic appearance. You get purpuric lesions, nodules. You might even get ulcers. And you get ulcers in Wegener's granulomatosis because it also involves the deep vascular plexus. You'll see antibodies to C-ANCA in 70 to 80%, and antibodies to myeloperoxidase in about 10% of cases. Here's sort of a classic clinical presentation. You can get the saddle nose deformity, you get mucosal involvement, and here's some vasculitic changes. Microscopically, at least in the cutaneous biopsies, you'll see leukocytoclastic vasculitis that involves the superficial and deep vascular plexus. And because you have involvement of the deep vascular plexus, the epidermis may get ulcerated. It is rare to see granulomatous vasculitis, although it does happen, but you will often see extravascular granulomas and geographic areas of necrosis in the dermis. Here's an example of granulomatosis with polyangiitis or Wegener's disease. Again, you can see a superficial and deep leukocytoclastic vasculitis. Look at all the hemorrhage. I think you can even, at this power, see fibrinoid necrosis of blood vessels and the neutrophils with prominent leukocytoclasis. There's a different case. In this case, had developed ulceration because, again, if you have vasculitis involving the deeper vascular plexus, you can get cutaneous ulcers. Here you can see, again, the leukocytoclastic vasculitis, perivascular neutrophilic infiltrate, leukocytoclasis. Here you can see some prominent geographic necrosis. Again, geographic necrosis here with this vasculitis, and it's extending here deep in, even into involving the subcutis. Here's an extracellular granuloma that you can see with Wegener's granulomatosis. And then only rarely do you see granulomatous vasculitis. Yes, there's a leukocytoclastic component, but there's also a histiocytic component around this affected vessel. Another type of superficial and deep vasculitis is allergic granulomatosis with angiitis or Churg-Strauss syndrome. And this one is an eosinophilic rich type of vasculitis. It classically involves the upper respiratory tract, but you can get cutaneous involvement in a significant subset. Patients will have peripheral eosinophilia. They, instead of having a C-ANCA, they have a P-ANCA in up to about 40% of patients. And remember, these also have significant systemic involvement. Cardiac involvement accounts for 40% of related mortality. You can get mononeuritis multiplex with systemic polyneuropathy. A third of patients will have GI involvement, and you also frequently have renal disease. So to make the diagnosis, you need to have 4 of the 6 following clinical criteria: asthma, eosinophilia, paranasal sinusitis, pulmonary infiltration, biopsy-proven vasculitis, or mononeuritis multiplex. Patients have cutaneous involvement anywhere from 40 to 70%. And again, you'll get purpuric lesions, erythema. You may get urticarial plaques, nodules, and even ulcers. And again, you get ulcers because the deep vascular plexus is involved as well. Here's a patient with Churg-Strauss syndrome. Notice these urticarial plaques. So you might wonder about urticarial vasculitis here, but the superficial and deep and denser infiltrate would be helpful. And this patient also developed ulceration. Microscopically, you see a leukocytoclastic vasculitis with eosinophilia. You'll often see tissue eosinophilia as well, in other words, interstitial infiltrative eosinophils. You will frequently, though not always, see palisading granulomas with numerous eosinophils. These are called Church-Strauss granulomas. This is not pathognomonic, it's just characteristic. And you will often see degranulated eosinophils. So here's a case of Church-Strauss syndrome, again, a superficial and deep leukocytoclastic vasculitis. You can see this, again, leukocytoclastic vasculitis here, lots of leukocytoclasis around these affected vessels. And you can see some degranulated mast cells here. And here, again, sort of numerous degranulated mast cells are forming a flame figure around this damaged vessel. You can sometimes, again, see this sort of granulomatous inflammatory infiltrate with degranulated eosinophils. Another characteristic. And just another picture of your leukocytoclastic vasculitis with frequent eosinophils around it. And then the last form of vasculitis we're going to talk about is microscopic polyangiitis. This is, again, one that is a superficial and deep vasculitis. Most common in middle-aged men. You get systemic small vessel vasculitis and with focal segmental glomerulonephritis. This is associated with P. ANCAs, and you get cutaneous involvement in 30 to 50% of cases. Again, the microscopic features are not specific. You tend to get superficial and deep perivascular leukocytoclastic vasculitis. You'll see arterial involvement. Again, you'll often see small vessel involvement. And again, because you have deep vascular plexus involvement, you may have epidermal necrosis, but it's not all that common. You have to exclude Wegener's granulomatosis and Church-Strauss vasculitis, and a lot of this is done clinically more so than histologically. So this is an example of microscopic polyangiitis. I think this is, can be exactly identical to what you can see in Wegener's granulomatosis, superficial and deep perivascular leukocytoclastic vasculitis, again, involving the deep vascular plexus. So you really need good clinical information to distinguish those. So when I get a case, if I get a superficial and deep perivascular infiltrate or perivascular leukocytoclastic vasculitis, if it doesn't have specific features like, granulomatous inflammation like we'd expect to see in Wegener's granulomatosis or eosinophilic granulomas like we see in Church-Strauss vasculitis, then I'll give a differential diagnosis of Wegener's, Church-Strauss, and microscopic polyangiitis. And, then it's on to the clinicians to try to figure it out after that. They can do serologic testing for ANCAs, etc. Another form of superficial and deep vasculitis is granuloma faciale. This is a localized form of vasculitis that tends to occur more commonly in men than women. It's usually on the face, and patients present with one or more erythematous to brown papules or plaques. You'll often get clinically dilated follicles and telangiectasia. They can be ranged from asymptomatic to mildly pruritic. And this is what it usually looks like, these sort of brownish plaques on the face. Microscopically, the microscopic features depend on when the biopsy is taken. Later on, if the biopsy is taken sort of in later stages of the disease, you'll see this dense polymorphic infiltrate that includes neutrophils, eosinophils, plasma cells, and lymphocytes. You may see some leukocytoclasis, but in later stages, you're not going to see the vasculitis. So you get this sort of dense mixed infiltrate with some leukocytoclasis and hemorrhage. In this clinical scenario, it's highly suggestive of granuloma faciale. And over time, lesions may become a little fibrotic. So this is, again, a biopsy of granuloma faciale. You can see a superficial and deep infiltrate. And you can see this mixed infiltrate. There's lots of neutrophils in here with leukocytoclasis. I see eosinophils. I see some plasma cells and lymphocytes. Again, I see leukocytoclasis, but I don't really see overt vasculitis in this particular field. Now over here, there is some remnants of vasculitis. You can see this vessel with these sort of hobnailing endothelial cells and the leukocytoclastic vasculitis surrounding it. Okay, we're going to leave vasculitis and talk about a form of lupus that is a superficial and deep pattern. Clinically, this occurs as erythematous plaques in sun-exposed skin. Microscopically, you see a superficial and deep infiltrate that is perivascular and periadnexal as well. And you will see increased dermal mucin, but essentially no interface change. So here's an example of tumid lupus erythematosus. Again, notice a superficial and deep perivascular infiltrate. Notice there's also a bit of an adnexal infiltrate as well. This is what dermal mucin looks like on H&E stains. You can see this subtle little bluish gray particulate matter between the collagen bundles of the reticular dermis. That's dermal mucin. All right, so remember that you tend not to see eosinophils in lupus. So if you see significant numbers of eosinophils, it is not lupus. Another superficial and deep perivascular reaction pattern are arthropod bite reactions. Clinically, these are quite variable, but most patients have one or more pruritic papules or sometimes plaques. Oftentimes, the epidermis may look normal. If you're lucky and it's very early, you might see acute necrosis of the epidermis, but most times, by the time they get biopsy, the epidermis looks normal. You may see some papillary dermal edema, and you classically see this wedge-shaped superficial and deep perivascular and interstitial infiltrate with lymphocytes and then often with some eosinophils. Here's an example of an arthropod bite reaction. The epidermis looks normal, but you have the superficial and deep infiltrate of lymphocytes, and I think even at this magnification, you can appreciate that there are frequent eosinophils that we see here. Practical tips: if you don't have a good clinical history, you can call something a superficial and deep perivascular mixed infiltrate or dermal hypersensitivity reaction with a comment when you're talking about arthropod bite reactions, and say the histologic features are compatible with the dermal hypersensitivity reaction. The differential diagnosis would include an arthropod bite reaction and that clinical correlation is recommended. And remember that drug reactions can look very similar, although the infiltrate is usually denser in arthropod bite reactions compared to drug reactions or urticaria. We're going to move on to an interstitial pattern in which the inflammatory infiltrate is either sort of nodular or more of a diffuse interstitial pattern. Entities that are included include Sweet syndrome, sarcoidosis, and lymphoid hyperplasia. I'm not going to talk about sarcoidosis today because I don't think that's very common in Pakistan. It's actually very common in the United States. If it is common in Pakistan, I can try to bring you a case when I come in October. We'll also talk about palisading granulomatous dermatitis. So nodular and diffuse pattern has a lot of overlap with the superficial and deep perivascular pattern, but you tend to have more interstitial infiltrate, and the infiltrate isn't just concentrated around vessels. It can be sheet-like or nodular. So here's a sort of nodular pattern. You can see, yes, some of the infiltrates are around vessels, but some of them are not. And it can be more of a diffuse or sheet-like pattern. Sort of the classic one is Sweet syndrome or acute febrile neutrophilic dermatosis. Patients present with violaceous tender nodules or plaques, can be associated with infections, underlying myeloproliferative disorders. Certain medications can trigger it, like granulocyte colony stimulating factors. Microscopically, you see no or only minimal epidermal change, and you have this dense infiltrate of neutrophils in the reticular dermis. You will see leukocytoclasis. You'll see fragmentation of neutrophils, but you do not see vasculitis, and you don't usually see significant hemorrhage. So here's a case of Sweet syndrome. The epidermis, yeah, you could argue there's a little bit of spongiosis here, but it's fairly normal considering how dense this inflammatory infiltrate is. Notice the papillary dermal edema. As we get to higher power, we can see leukocytoclasis of neutrophils, but there's really no hemorrhage or vascular damage. This is a vessel. The endothelial cells are kind of plump, but there's really no hemorrhage, and there are lots of neutrophils and leukocytoclasis, but no real damage to the vessel. So again, the differential diagnosis can include leukocytoclastic vasculitis, but again, you'll look for vascular damage. Rheumatoid neutrophilic dermatosis, that can look identical to Sweet syndrome, so you really need to know clinical history. Pyoderma gangrenosum will show a dense neutrophilic infiltrate, but there's ulceration. And we'll talk about pyoderma gangrenosum not today, but in a subsequent lecture. So practical tips for Sweet syndrome. There's no true vasculitis. You only rarely see ulceration in Sweet syndrome. You don't usually see eosinophils in Sweet syndrome. So if you see eosinophils, think about an arthropod bite reaction or some other dermal hypersensitivity reaction. So oftentimes my top line diagnosis is neutrophilic dermatosis, see comment. And then I will say in the comment, the histologic features are consistent with Sweet syndrome. If there is suspicion for an infectious etiology, tissue culture is recommended. And it's always reasonable to do infectious stains in Sweet syndrome. To do like a GMS stain or a Gram stain and look for infectious microorganisms. So it's important to exclude those possibilities. What about B, cutaneous lymphoid hyperplasia, reactive lymphoid hyperplasia? Also previously has gone by the name of lymphocytoma cutis. Most patients present with a solitary nodule or plaque, most common on the head and neck. In some areas of the world, it can be associated with Borrelia infection. That's not as common in the United States. Microscopically, you tend to see a more top-heavy nodular to diffuse lymphocytic infiltrate. You may see some admixed eosinophils and plasma cells. You may see germinal centers. And when you do see germinal centers, they're often polarized. And another thing that you will see that helps you distinguish it from, say, follicular lymphoma, if you see significant numbers of tingible body macrophages in the germinal center. Just remember that reactive lymphoid hyperplasia in the germinal centers have a very high Ki-67 labeling index. That's an expected finding in reactive germinal centers. Here's an example of B-cell lymphoid hyperplasia. You can see these nodular aggregates. You can start to see these germinal center formations. And notice the germinal centers are polarized. In other words, you have larger lymphocytes on one side of the germinal center and more smaller lymphocytes on the other side of the germinal center. And at higher power, you can see these tingible body macrophages, these macrophages containing small nuclear fragments. It's rare to see that in follicular lymphoma. And just remember, reactive germinal centers have a high Ki-67 labeling index. You can do a whole other range of immunohistochemical stains, but I don't really have time to talk about, all sorts of cutaneous lymphomas. That's sort of beyond the scope of this lecture. So the differential diagnosis includes follicular center cell lymphoma, primary B-cell follicular center cell lymphoma of the skin, or systemic involvement. You can do clonality studies. You can do various immunostains. Marginal zone lymphomas, you will usually see a clonal population of plasma cells and expanded germinal centers. This is a diagnosis I do approach with caution. You have to exclude lymphoma with various immunostains, consider clonality studies. And then my diagnosis is usually something like this: cutaneous lymphoid infiltrate consistent with the reactive process, with a comment. I will describe it, and in my comment, I will always recommend continue clinical follow-up. And if this process persists or progresses, then you're probably going to need additional biopsies. Now we're going to move on to palisading granulomas, and that'll be the last part of the lecture for today, I think. And I may squeeze in one more thing, but we're going to talk about granuloma annulare, rheumatoid nodule, and necrobiosis lipoidica. So the characteristic feature of palisading granulomas, you'll see an interstitial infiltrate of histiocytes with altered collagen. So this is what it is in cartoon form. You see histiocytes surrounding areas of altered collagen. Granuloma annulare is the most common form. You see asymptomatic papules, often, though not always, with an annular configuration. Usually it's on the extremities, but you can see it anywhere. Microscopically, granuloma annulare usually involves the upper third of the dermis. So usually the upper and mid reticular dermis. You will see a central zone of altered collagen often associated with mucin, but that's not always prominent, surrounded by histiocytes. You may see a few giant cells too. It is important to know that there's an interstitial pattern of granuloma annulare that is relatively common. You may see a few eosinophils or neutrophils in the background too, but predominantly it's lymphocytes or histiocytes with some admixed lymphocytes. Rare cases can resemble sarcoidal granulomas. Rarely can be found to the subcutis, and this is deep granuloma annulare, and deep granuloma annulare is almost always in young children on the lower legs. So here's a classic case of granuloma annulare, and this is a diagnosis that I think is best made at low magnification. You don't want to go to high power to make this diagnosis. So here's this sort of central area of altered collagen that's surrounded by histiocytes and some lymphocytes. Another sort of palisading granuloma here and here. You see these histiocytes surrounding these altered collagen. Just a little bit higher power picture, you can see all these histiocytes and these sort of altered collagen fibers and then surrounding lymphocytes. Here's a few multinucleated cells as well. Here's a case with a more interstitial pattern. And the interstitial pattern, it's subtle. It's not as well developed of a palisading granuloma. Here you can see this interstitial infiltrative histiocytes intercalating between these altered collagen fibers and maybe a few lymphocytes at the periphery. Now, I think that these altered collagen fibers look more red or more eosinophilic compared to the non-involved collagen fibers. And I think that's a nice subtle clue to interstitial granuloma annulare. At higher power, you can see this interstitial infiltrative histiocytes and these altered collagen bundles. This case happens to have a few eosinophils. So one of the differential diagnoses can include an interstitial granulomatous drug reaction, which can look identical to interstitial granuloma annulare, so you need good clinical information. This is deep granuloma annulare, and in deep granuloma annulare, the inflammatory infiltrate is in the subcutis. You get these deep palisading granulomas involving the subcutis. And remember, deep granuloma annulare is more commonly seen in children. And here you see this palisading granuloma with these sort of altered collagen and necrotic debris in the center. Looks a lot like a rheumatoid nodule, but the clinical scenario is different. Practical tips for granuloma annulare. Just remember the interstitial pattern is relatively common, so you don't always see a really well-developed granulomatous palisading granuloma. I think it's an easier diagnosis to make at low magnification than high magnification. I think the altered collagen looks a little more red or a little more eosinophilic. Again, remember the interstitial pattern is common. And if you see deep granulomas in the subcutis, think about deep granuloma annulare, which usually occurs in children. It's rare to see it in patients older than, say, 25 years of age. Now, the differential diagnosis can include a lot of different things. We're going to talk about primarily necrobiosis lipoidica and rheumatoid nodule. We don't really have time to talk about granulomatous drug reactions, although they can look a lot alike, or sarcoidosis. I think at low magnification, dermatofibromas can look a lot like granuloma annulare, but the clinical presentation is very different. And epithelioid sarcoma can sometimes look a lot like granuloma annulare. Necrobiosis lipoidica is clinically different from granuloma annulare. Usually you see this yellow to orange indurated plaques, most commonly on the lower legs. Some patients have underlying diabetes, but usually not all. Usually it's a minority of cases. Now, in granuloma annulare, the inflammatory infiltrate tends to be in the upper half of the dermis. In necrobiosis lipoidica, it tends to involve the entire dermis. And in necrobiosis lipoidica, you don't have circular palisading granulomas, you have more layered or tiered palisading granulomas. So you have sort of a stripe of altered collagen separated by an interstitial infiltrate of histiocytes, and I'll show you a picture of that. You'll often see multinucleated histiocytes. And another feature that you tend to see in necrobiosis lipoidica that you do not see in granuloma annulare are plasma cells. So here are clinical examples of necrobiosis lipoidica. Again, it's more common in the lower legs. You see those orangish to yellowish plaques. Now, microscopically, Necrobiosis lipoidica has a tiered arrangement. Now, so you have this sort of stripe of altered of histiocytes and this other layer or stripe of altered collagen. Stripe of histiocytes and stripe of altered collagen. Stripe of histiocytes, stripe of altered collagen. Now, depending on if you have a sweet tooth or a savory tooth, it might look like a layer cake. And at least in our country, we like bacon. I'm sure that's not a common thing in your country to eat bacon, but it has this sort of stripe of altered collagen and stripe of histiocytes. So it can look at low power like a layer cake or a piece of bacon. So again, you have this zone or tier or horizontal stripe of inflammatory cells and a horizontal stripe of altered collagen. And that just sort of progresses all the way down the dermis. And it can start to impinge on the subcutis. So again, the stripe of histiocytes and other inflammatory cells, altered collagen, another layer or tier of inflammatory cells, and altered collagen. Again, multinucleated cells are common, and if you go to higher magnification, you'll often see some plasma cells, which is not a feature of granuloma annulare. So again, this is a diagnosis best appreciated at low magnification. You see layers or tiers of altered collagen separated by histiocytes that sort of creates like a layer cake or bacon-like appearance. If you see plasma cells, it favors Necrobiosis lipoidica over granuloma annulare. Most cases are on the legs. And if you're uncertain, and that happens sometimes, you can make a diagnosis of palisading granulomatous dermatitis, and then in the comment describe it, and if you can, favor one over the other. Rheumatoid nodules. About 30% of patients have with rheumatoid arthritis will develop rheumatoid nodules. They're not only associated with rheumatoid arthritis, though. You can also see it in patients with lupus erythematosus. Typically occurs near joints, so around the elbow, around knuckles, that we see these rheumatoid nodules. Microscopically, they tend to be located in the subcutis or deep dermis or even deeper soft tissue. And what you have these cellular areas of necrotic cellular debris surrounded by a palisade of histiocytes. Lymphocytes, plasma cells, and eosinophils may be present. This is a higher power picture of a rheumatoid nodule. Again, these palisade of histiocytes surrounding this necrotic cellular debris. And again, this looks identical to what you might see in deep granuloma annulare, but the clinical appearance is different. The clinical situation is different. Just to be aware that epithelioid sarcoma can sometimes have a palisading granulomatous appearance. You can see the sort of what looks sort of like a palisading granuloma at low magnification, but if you get to higher magnification, you can start to see these tumor cells that have significant cytologic atypia. And of course, epithelioid sarcoma will be positive for cytokeratin on immunohistochemical stains. And with that, this is the end of part 2. And we will figure out the best time to do part 3 and maybe do it next week if that works for you. And I'll be happy to take any questions. I see some questions in the chat.
Thank you so much, Dr. Stephen. There are certain questions on the chat box, and I think
Okay, granulomatous lesions, fungal and bacterial granulomas without special stains. Please share your experience. Okay, well.
Dr. Anita, yes. Samina, any role of peripheral blood eosinophila in the differential diagnosis of urticaria and eosinophilic infiltrate in the dermis?
I'm sorry, could you repeat that? Peripheral eosinophilia is very important for making a diagnosis of Churg-Strauss syndrome. I don't think it's really helpful with urticaria, but it's critical for making a diagnosis of Churg-Strauss syndrome.
Okay, another is Zainab Raja. Is incisional biopsy preferable as compared to punch biopsy in case of vasculitis, or punch biopsy is fine?
Well, and in my experience, a good punch biopsy should be adequate if you biopsy
Yes,
if
punch
it's in the
biopsy is
lesion.
better. Yes, yes.
You know, I mean, in the United States, it's hard to get people to agree to doing an incisional biopsy.
Yeah,
But punch biopsy is usually adequate.
better.
And a question about granulomatous lesions, fungal and bacterial granulomas without special stains. Well, I think it's reasonable anytime you see granulomas in the dermis to do special stains. I think it's hard to make a diagnosis of an infection without a special stain, though, at least from a pathology standpoint. And certainly not always are the special stains positive, even if it is an infectious process. So I guess if I see granulomas and if I'm worried about an infection, I will do special stains. But I will also put in a comment that, you know, this could still be an infection even if the special stains are negative. You know, and if the clinician is worried about infection, they should make sure they should do cultures. Because, you know, if the special stain is positive, it's great. But if a special stain is negative, you can't exclude it. And, you know, I didn't really put in talk about infectious diseases, just it's not part of this normal lecture, but certainly doing special stains like AFB stains, GMS stains are very helpful. And GMS stains are a little more sensitive than PAS stains for granulomas, for infectious disease. I always do, if I'm worried about a mycobacterial infection, I always make sure I do a phyte stain. I find that more sensitive for the atypical mycobacterial infections, which is the type of mycobacterial infections I usually deal with. So if you have like granulomas on the hands, and I will frequently consider doing a phyte stain. We do sometimes see cases of Hansen's disease or leprosy in the United States, usually especially in patients from the southern United States. So we do sometimes see that. So we will do mycobacterial stains if we're worried about that, especially if it has significant perineural inflammation. All right.
And what about parasitic granuloma?
Parasitic granulomas, I almost never see those. I mean, in my practice, very rarely do I see strongyloidiasis. And then I'll look, usually I'll see the worms in the dermis. I don't usually need to do a special stain to see that. Can sweet syndrome be confused with leukocytoclastic vasculitis? Yes, it can, because of the leukocytoclasis. But remember, if you look carefully at the vessels in sweet syndrome, the vessels themselves are not damaged, and usually there's not much hemorrhage in sweet syndrome. So there's leukocytoclasis, but no hemorrhage and no vascular damage.
Yes, these are two difference between the sweet syndrome. But clinically, can they look like?
Clinically, usually sweet syndrome is larger plaques, and most cases of leukocytoclastic vasculitis are small papules, but not always, because I certainly showed you cases of plaque-like, you know, vasculitis with Churg-Strauss syndrome, but that would have more eosinophils.
Okay.
We don't see a lot of cysticercosis in the United States, so I can't really comment on that so much. I've seen a few cases.
But here in
yes,
Pakistan, in
granulomas.
India and Pakistan, this is we see usually here.
I recently saw a case of cysticercosis that was mimicking abdominal carcinomatosis. That was a fascinating case.
Yes, palisading granuloma is seen in the cysticercosis. Yes, in Pakistan and India and in Bangladesh. And Dr. Zainab Raja, Stevens, okay, quite informative. Over to you, Dr. Zahida Rani, Professor Zahida Rani, and Dr. Zunaira. Clinicians are here.
Assalamu alaikum.
Ji.
Another excellent lecture by Professor Stephen Billings, and surely we are much more knowledgeable about the respective diseases now. Hope to have hope to learn from you in the future regularly.
I'll be happy to try to do that.
Inshallah, in the third lecture. And Dr. Stephen, we will have also request you for one more lecture on the malignant diseases, because no doubt and the third lecture will complete the certain
yeah, the third lecture will be complete inflammatory dermatoses. But
yes,
I
at the
would
end
be
of
happy
this
to put
Yes, at the end, we will request for the fourth lecture on the malignant tumor. Thank you so much, inshallah. See